Hello and welcome. Thank you for joining us on today's webinar, Is Uterine Fibroid Embolization Right for You? My name is Daisy Diaz and I will be coordinating this live Q&A here with Dr. Michael Lalazarian, who is an expert in uterine fibroid embolization here at ProFibroidMD. Dr. Michael Lalazarian is a board-certified physician specializing in vascular and interventional radiology. He is known for his patient-centered approach and committed to advancing minimally invasive care. Dr. Lalazarian has built a reputation for clinical excellence and innovation in minimally invasive fibroid treatments. He is the founder and medical director of ProFibroidMD, where he leads a team focused on delivering high-quality, evidence-based procedural care. After finishing his medical training, including residency and fellowship at the David Geffen School of Medicine at UCLA, he has stayed on in a volunteer teaching capacity where he trains residents and fellow interventional radiology physicians. He has a particular interest in complex, challenging fibroid disease and treating women who have recurrent symptoms after undergoing prior fibroid treatment.
Thank you, Daisy, for the warm welcome. I really want to keep this really casual. It's more of a discussion. I encourage your questions. Please enter them, and we will really get to them at the end. And there's really no bad question. And we're going to start off, Daisy has several questions of her own that I think will be helpful in leading our discussion today.
Yes, so let's go ahead and get started. So first question is, Dr. Lalazarian, what exactly is UFE, or uterine fibroid embolization, and how does it work?
That's a great question. We actually get this basic, simple opening question very often. So UFE stands for uterine fibroid embolization. It's also known as uterine artery embolization, or UAE. And essentially the way it works is that we reduce the blood supply to the fibroids to shrink them and deprive them of blood, which is something they really need to survive. Going back to what fibroids really are, essentially they're benign tumors. And they're growths that form in any part of the uterus, and we don't really understand why they occur, other than we know there's a strong genetic factor. And so there's really nothing women can do to make them worse or to make them go away. It's sort of a luck of the draw. But we do know that they really love blood supply. Without it, they do not prosper, and we take advantage of this with embolization. So embolization is really a technique in which the physician will go through the blood vessels with what's called a catheter, a tiny little kind of spaghetti-sized tube with a small puncture. It's minimally invasive. And we arrive to the blood supply of the entire uterus, not just one particular fibroid, and we inject particles or little sand-like material that goes to the end of the pathway of the blood supply to the fibroids and plugs up that pathway. And really, essentially, immediately, blood flow to the fibroids stops. And that's really where the magic happens. And so for bleeding symptoms, for example, and we'll get into what symptoms could be for fibroids, those are almost immediately solved. And then even for bulk symptoms, meaning symptoms that are related to the size and the presence and the pressure related to the mass effect, that also responds, but takes a little bit more time. And so those are the nuts and bolts of embolization.
Got it. Thank you for that, doctor. And what are the main benefits of choosing UFE over, let's say, a traditional myomectomy or even the common, which is a hysterectomy?
Also a question we get very commonly, and it's important whenever we make a treatment decision to really know all of the options, and because each option has advantages and disadvantages. Historically, hysterectomy has been the gold standard treatment. The uterus is taken out surgically, the fibroids come out with it. We're sort of done with the fibroid problem, essentially. However, it's surgical, it's invasive, and with any open surgical invasive procedure come risks, some that are immediate, but then some that come many years later. And so over time, we've gotten better at becoming less invasive. And embolization is kind of at that least invasive of these three options in terms of the spectrum. And so myomectomy, to kind of answer your question in completion, is when a gynecologist will either laparoscopically or open surgically cut out and remove individual fibroids. There are circumstances in which a myomectomy really shines. However, in my opinion, for many cases, and I would say most cases of benign fibroids, which is really the most common circumstance, embolization is probably the best option in that it's least invasive, there's the least amount of downtime, there's really no scarring, many of the surgical complications are off the table, and all of the fibroids, really essentially, we target all of them at once. Unlike a myomectomy where individual fibroids may be cut out, it's a blanketed approach with embolization. And so it's important, however, having said everything that I have, that you consult your physician for all of these options and you choose a physician who really discusses all of them because there is not a one-size-fit-all for every woman.
Got it. So speaking of risk, I know you mentioned risk and you mentioned complications. What would you say are, if any, the possible risks or complications in getting an UFE?
Every procedure has risks, and it's important to be aware of that. Embolization, when we look at it compared to other surgical procedures and surgeries, is extremely safe. And that's to a large degree because it's not done under general anesthesia. In fact, we use really minimal sedation because the procedure itself is not painful. It's also safe because we're not cutting the body open in any way. It's really a 2 millimeter puncture the size of a pencil tip that's done either at the wrist or in the groin. And by nature of that very small incision, we really put away a lot of complications. However, having said that, there are complications that are unique to UFE. For example, very large fibroids can very uncommonly become infected after they're embolized. We really don't see that often. It's extremely rare, but it can happen. Other complications are an abortion of a fibroid. For example, if there's a fibroid that's sitting inside the cavity of the uterus on a stalk, we call those intracavitary fibroids. The stalk can actually break off after embolization, and a woman can pass that fibroid. Again, this is extremely uncommon, but it can happen. Other complications are injury to the artery at the groin or the wrist where we go in the body. So there certainly are complications. I would say on the whole, they're not common, especially in experienced hands, and that you can discuss these complications further. I would say on the whole, UFE is safer than hysterectomy or other surgical options.
So what does the recovery process look like? So how soon, if I were to get UFE, uterine fibroid embolization, how soon am I back to work and back to my normal activities?
I think that's where UFE shines. There is certainly some downtime with UFE. The first day or two, the uterus and the fibroids are deprived of blood and oxygen, and the fibroids get really angry. There's a lot of inflammation that happens in the uterus and within the fibroids, and that inflammation causes pain. And so what I tell my patients is that for about a day or two, it's not a walk in the park. Much easier than an abdominal incision or pelvic incision. However, those first couple days, we really want to be home. You're going to be walking and eating, but you take those couple days off. We have medications that I prescribe, kind of a cocktail that I've refined over time that's really designed to keep women comfortable at home those first 2 days. I tell women that by day 7, almost all of them will be back to work, depending on what they do for work. If you're working from home and you have a desk job, probably day 3, you're back to it. So on the whole, as opposed to a hysterectomy where the recovery time is anywhere kind of in the 4 to 6 week range, UFE, I put it at the first 2 days are rough. It gets much better after 2 days. Cramping and discomfort in the pelvis can linger for about a week or two at a much milder level.
Got it. So you did mention the fibroid shrinking. So what kind of shrinking can be expected, and what type of symptom relief from fibroids are to be expected?
That's a really common question that we get. And so what I first tell women is that the purpose of embolization is to shrink the fibroids, not make them disappear, okay? Because by shrinking the fibroids, we actually achieve a lot of what we call the clinical benefit, the symptom relief, which is, remember, what we set out to do. And so we shrink about 50% on average at 6 months. So after we embolize, on that day is the beginning of that shrinking process. And we see that on average, if we were to do an MRI at 6 months after and compare it to before, that's typically what happens. Keep in mind, however, there's another component that during every menstrual cycle where there's a surge in estrogen, the estrogen actually promotes growth and stimulates that fibroid in that moment. And so even for those several days of the cycle, the fibroid is especially angry and engorged. And we blunt that response. That we know when that fibroid, that ball of tumor has lost its supply, it can't engorge. And that's really how we achieve symptom relief. And so, I ask my patients not to fixate so much on percentage of shrinkage. It's really look at how much you were suffering before, and then let's look at how much you're suffering after. And in that way, we really make a substantial improvement.
So now, and for our final question, I want to say this is probably going to be the $1 million question. How do I know if I'm a good candidate for UFE?
Yeah, so that's the best and only way, really, is to consult a physician. That's the first thing I'll have to say. Secondly, I'd say is that most women, I'd say almost all who have fibroids who are suffering from them are going to be candidates. There are rare exceptions, and I'll sort of talk about what those exceptions might be. This is not an exhaustive, complete list, however. For example, in the very rare chance that we're suspicious that this is not a fibroid, this might actually be some type of cancer. Okay, well, in our world, we call it a sarcoma. There are some imaging features that would support that. If we are at all suspicious about that, that individual would not be a candidate for embolization. Aside from that, as long as a physician, I'm convinced that the symptoms are significant and attributable to fibroids and they match up and there's not really another alternative explanation, embolization is extremely effective in my experience and in others, and I really think should be considered as a first-line option. And really, so it's really to get in for a consultation and to really have somebody look over everything. In terms of effectiveness, I want to touch on that as well. I like to divide the symptoms related to fibroids into two categories. I'd say in one bucket, we have bleeding, which is very common, especially when the fibroids touch the inner lining of the uterus, or what we call the mucosa or endometrium. The second bucket of symptoms are bulk symptoms. We touched on this earlier. Presence and size of mass effect. Urinary frequency, constipation, peeing a lot in the middle of the night, bloating, pressure, all of these symptoms become pronounced during the cycle. That's how I'm convinced that it's related. And these two buckets are both treatable by embolization. About 90% effective for bleeding is what the literature says. I've seen that to be true in my practice. About 80% effective for bulk symptoms is what is said in the literature. I've also seen that to be true. And in many cases, women have symptoms in both buckets. And so we really tackle both at once with one procedure.
Got it. Alrighty, so I don't see any questions in our chat box. I do encourage any of you to go ahead and submit a question if you guys have any questions. If not, if we answered many of your questions, we're glad that we did. Oh, we have one here. Okay, so question is, are fibroids after menopause treatable?
Hi, Anna. Thank you for your question. This is actually a question I get often. I mean, we do see postmenopausal women in our clinic who come in who didn't really experience symptoms perhaps before, but after menopause, for whatever reason, they become more apparent. The first thing I'd say is that hormonally, once estrogen is sort of going to the wayside, which happens in menopause, fibroids do naturally shrink and subside. That's the first thing I'll say. However, there are an increasing number of women, especially as black box warnings are going to the wayside with HRT or hormone replacement therapy, that are seeing growth of fibroids or stimulation that happens in the postmenopausal stage. And so the answer is yes. Postmenopausal women are treatable with UFE. It does require a little more technical skill on the part of the physician because the arteries are smaller and harder to get into. However, in experienced hands, it is an option, and I've treated many women that are postmenopausal.
Okay, we do have another question as well, doctor. Question is if fibroids cause anxiety, as I've been suffering for years and have a UFE consult on Thursday. I have all the symptoms you mentioned and need relief.
So fibroids don't cause anxiety directly per se, right? There's no kind of hormonal release of any kind of chemical that would stimulate, the nervous system in that way. However, any medical condition that causes disability or disruption to your life or quality of life can cause anxiety. And fibroids can cause other medical conditions such as chronic anemia or, from losing too much blood, which can then in turn cause medical issues and therefore anxiety. So not directly. However, we do see that women who are really suffering from pelvic conditions such as fibroids have higher incidences of anxiety or depression or other kind of mental health issues.
So, Dr. Lazarian, another question that we have here, what is the role of imaging for fibroids? And does somebody need imaging before they come in for a consultation?
This is another very common question that I get. And we have several different ways to image or look inside of the pelvis. And really for uterine pathology or fibroids, ultrasound and MRI are probably the two best ways, and for good reason. They both are without radiation. The pelvis is a very radiosensitive part of the body, especially in younger women. And both ultrasound and MRI provide a very simple way to identify whether fibroids are there, how big they are, where they are, how much blood supply they might have, and whether they're pushing on adjacent organs. Importantly, also, it's another way to know whether there's another medical problem that might be in the mix that we want to rule out before we hone in on the fibroids. And so I'd say ultrasound and MRI are really the two best tools. Ultrasound is a good screening tool. Oftentimes, we then upgrade to an MRI to really get more detail. Do you need imaging before you come for a consultation? Most women somehow have arrived at the diagnosis of fibroids before they come to us. So I encourage them to bring all prior records. Bring your prior imaging. We may repeat it, especially if it's been some time. We may want a current snapshot of what things look like. We also may do imaging after treatment. I like to have what we call baseline imaging, or perhaps an ultrasound or an MRI that's sort of right before we treat, so that 6 months or a year later, we have a good comparison to see how much we've shrunk, how much the fibroids have responded, perhaps. And so imaging is an important part of both evaluation and post-treatment evaluation.
Okay. Looks like that was all the questions that we have today. I do want to thank everyone for joining our live Q&A, joining this webinar. We really appreciate you guys joining. And please reach out if you guys ever do have any questions, whether that be maybe after the webinar, a question does arise. Please feel free to reach out to me or to our info@provascularmd.com website. We'd be glad to answer any of your questions and be available to help you guys. If anyone would like to schedule an appointment, they could also reach out to our office or schedule an inquiry online through our website as well.
Thank you, Daisy. Thanks for your time. And thank you for everybody for joining. We will hopefully have more in this webinar series in the future, and there's so much more to talk about.
Yes, thank you for joining, guys.